So we are starting with a new topic here, which is that of the viral uveitis, and we are going to start with the human immunodeficiency virus and uveitis and HIV infection. So let's begin. We'll start with the introduction, as we always do. So HIV is transmitted by unprotected sexual intercourse via contaminated blood or needles, vertically from mother to child, transplacentally during birth, or breastfeeding. HIV depletes CD4 T cells, which are vital to the initiation of the immune response to pathogens. Although there is currently no cure or vaccine, the progression of disease can be slowed radically by combination drug therapy, which is antiretroviral therapy, ART. ART is now recommended for all HIV positive individuals, irrespective of CD4 T cell count. Prophylaxis against opportunistic infection may also be instituted. Patients usually present in clinics with their systemic features. Initially, it is divided into the stages of infection. There is a flu-like illness which may occur 2 to 4 weeks after infections, and sometimes it includes a rash. After that, there is a clinical latency and is a predominantly asymptomatic period of several years, average of 8 years, sometimes with minor clinical features such as persistent generalized lymphadenopathy. And after that, acquired immunodeficiency syndrome or AIDS develop in about half of HIV positive individuals within 10 years, and is defined as HIV infection with either a CD4 T cell count less than 200 cells per microliters, or the development of one or more AIDS defining conditions. Now, there are certain AIDS defining clinical conditions, and we are going to discuss each one of them. First one is the opportunistic infections. So, there are certain infections which are usually not found in immunocompetent individuals, such as respiratory or esophageal candidiasis. For one, pneumocystis jirovecii pneumonia, very typical in AIDS patients. Cryptosporidiasis and cytomegalovirus retinitis. Then there are specific tumors such as Kaposi sarcoma, which is very specific to AIDS patient. This patient here has sarcomas, multiple of them on his face, and Kaposi sarcomas is very typical of AIDS patient. And certain lymphomas, especially B-cell lymphomas. Other manifestations are HIV wasting syndrome, which we have seen in countless movies as well. Another presentation is progressive multifocal leukoencephalopathy. So we are going to go ahead with the ocular features. Now, we are going from anterior to the posterior segment. So first of all, eyelid, there would be blepharitis and multiple molluscum lesions. Immunocompetent patients also present with molluscum lesions, but they are not as widely spread as in a patient with immunodeficiency or AIDS patient. And this can be present all over the face. Kaposi sarcoma can also be present on the lid, and herpes zoster ophthalmicus, which is way out of proportion as compared to in an immunocompetent patient. Then coming to the orbit, atypical orbital cellulitis, usually caused by fungal infections in AIDS, is caused by aspergillosis, contiguous sinus infection, and B-cell lymphoma, as I already mentioned. Then there is conjunctiva, and in conjunctiva the presentation can be by with Kaposi sarcoma again, squamous cell carcinoma, and microvasculopathy, which is in up to 80% of the patients. In cornea, patients present with keratoconjunctivitis sicca and increased incidence of keratitis, for example, by herpes simplex and zoster, and fungal keratitis as well. Then anterior uveitis associated with ocular infections or commonly with drug toxicity, the antiretroviral drugs, most commonly caused by rifabutin and cidofovir. HIV-related microangiopathy is the most frequent retinopathy in patients with AIDS, developing in up to 70% of patients. It is associated with a declining CD4 T cell count and a higher plasma HIV RNA levels, and is a marker for increased cytomegalovirus retinitis risk. Now, postulated causes include immune complex deposition, HIV infection of the retinal vascular endothelium, and abnormalities of the flow. It manifests with cotton wool spots, as seen here. These ones are the exudates, and or retinal hemorrhages. These are flame-shaped hemorrhages in the diagram here. And sometimes capillary abnormalities like microaneurysms. I don't see any microaneurysm in this figure, but they're very easy to identify. In contrast to cytomegalovirus retinitis, lesions are usually asymptomatic and almost invariably disappear spontaneously after several weeks. Other viral retinitis, like cytomegalovirus retinitis, which is most common, then progressive retinal necrosis and acute retinal necrosis. These are the topics I will discuss in details in the next upcoming lectures. Then protozoal, like toxoplasma retinochoroiditis, which is often atypical. We have discussed it in the parasitic uveitis, and fungal, like atypical fungi, pneumocystis choroiditis and histoplasmosis chororetinitis. And bacterial are syphilis and tuberculosis. Then neoplastic is B-cell intraocular lymphoma. Neuro-ophthalmological presentations are usually secondary to meningitis or encephalopathy due to opportunistic infection, for example, toxoplasmosis, cryptococcus, neurosyphilis, or neoplastic process such as CNS lymphoma. So there is humongous involvement of ocular structures in AIDS, and treatment is systemic antiretroviral treatment. We have to keep an eye for the diagnosis side and refer the patient to the infectious disease specialist for systemic treatment. Otherwise, we will treat the patient according to the symptoms. And that's it for now. If you like the lecture, please subscribe and click on the like button. Thank you all for listening patiently.